Good evening, ladies and gentlemen. Welcome again to the Seminars in Surgery. It's always a pleasure to be here and discuss how we can be of assistance to our patients. Constipation is something that we see in our practice every day, whether it be in children or adults. It's something that we have to deal with every day. And often, if you don't work with children every day, you don't know how to deal with it. And most of the time, we often misdiagnose or miss serious conditions. And sometimes we don't even know what to do with the child who is constipated. And so today, we are really honored to have Dr. Marie Kirsten as our guest speaker. As Dr. Mawela was saying, Dr. Kirsten has over 3 decades of experience working with children, especially children with constipation, as well as incontinence. Just a brief background, Dr. Marie was actually born in the Eastern Cape, in a small town called Begersdorp, and she completed her undergraduate studies in the Free State. And she then moved to Pretoria after she was married to her husband, Mr. Willem Kirsten. That's when she moved to Pretoria. From there, before she was appointed as a medical officer, she had already completed her College of Medicine diploma in child health, and that was in 1986. And I'm sure some of our participants were not born at that time. So she's been in pediatrics for a while. So she's been in Steve Biko in the Department of Pediatrics, pediatric surgery since 1990. And she's been working with children with constipation and incontinence since then. And her experience or her passion doesn't only end there. She's also involved in some trials and studies, particularly some studies involved with rotavirus. She's also written a chapter as well in one of the pediatrics and childcare books about constipation. And her involvement in research has contributed significantly in literature in terms of the role of rotavirus in intussusception, vitamin B12 deficiency after bowel resection, terminal ileum specifically, resection after intussusception. So she's also contributed significantly in literature. So we are really honored to have you, Dr. Kirsten, and thank you very much for making time from your busy schedule to come speak to us. So without wasting any further time, ladies and gentlemen, I think we'll give Dr. Kirsten the platform to start with her talk. Thank you.
Thank you.
Good evening, everybody. It is a privilege for me to share with you my experience, and sometimes I call this topic my hobby. And some people might find that a little bit strange. What I used to tell the students when we give them tutorials, every topic that we discuss with them, there's actually 1 or more textbooks written about that topic. So what can one say in 1 hour is just the highlights. I like it when we do discussions interactive, so you're more than welcome to ask questions or make comments in the chat box. And some of the slides we might be able to have a poll, and that's always interesting for me to see what people think and where they stand with their knowledge and experience. So to start with, we need to define the topic. What are we actually talking about? And when I started my career and read about this topic, I found it very interesting that every author would have his own definition at the beginning of his article and say, well, in our department, this is what we call it. But fortunately, we've advanced, and now we are talking about the Rome 4 criteria. Now, the Rome 4 criteria was published in 2016, which means that the gastroenterology international meeting had to get together 4 times before they could agree on these things. I'm not going to go through the detail of this. You'll have my slides afterwards and you can look through it. But it's important that you at least have an idea what is the definition before you just write it down. The most important thing for me is that you and the patient, or then the patient's mother, that you're on the same page. So if you ask the mother, is your child constipated? And she says yes, you shouldn't write in your notes, this patient is constipated. You should make sure that it fits this definition. Is there 2 or fewer defecations per week? Is there a history of excessive stool retention? How do you have that history? They won't pass stools for several days. And then when they do, it's a massive stool. The mother would sometimes come with a 6-year-old child and say, doctor, I thought there was an elephant in my toilet. It's a massive salami. That's the other interesting thing, is that they often compare what stools look like to food. And initially I thought it was very funny, but I've learned not to laugh in their faces about this. So a history of painful or hard bowel movement. So in a baby will cry a lot when passing stools, and bigger children will say it's very painful. And also then maybe they'll decide not to go to the toilet because of that. This large diameter stool can sometimes really block the toilet. And when you examine this child, you can feel this large fecal mass in the rectum or in the abdomen. And then with toilet-trained children, we also know that the history of incontinence after they were already toilet-trained, that means that most probably they have fecal impaction with an overflow incontinence. But then we must get back to the beginning and understand what is a normal frequency of stools in a neonate, or then in different other age groups, because it's not the same in everybody. And this one, I think it's important for people to know that the breastfed baby can have 7 stools on one day if the mother has a lot of milk and she is feeding this baby on demand, meaning every time when he cries, she would put him on the breast. Or it could be 1 stool in 7 days if the mother has just enough milk. And don't make a mistake. If a breastfed mother says, my child is passing stools only once a week, that you immediately think this is a serious problem, that this has to be constipation. Make sure about the other stuff. And of course, don't treat for diarrhea when they've got overflow incontinence in older children. Then you're actually worsening the problem. But how do you evaluate the hardness of stools? Well, you can ask the mother, and maybe in the newborn baby, she will tell you it looks like yellow toothpaste, or she might say it looks like custard. You know that the newborn baby stools are very, very yellow. Or you can go to the Bristol stool chart. There are different ones. I actually prefer the colored one that was published in England. And there you can see what we call constipation is type 1, 2, and 3. It looks like rabbit droppings, or like a bunch of grapes, or like corn on the cob. Or then a snake-like stool or a sausage is a normal stool. And chicken nuggets, we also say that is still normal size stools. Porridge and gravy is then might be diarrhea or looser than normal stools. And I've got a copy of this chart in my clinic, and I then show it to them and say, choose your poo. And it's also interesting that sometimes the mother and the child would argue and say, I think it's number 3. No, mom, it's actually number 2. But if it's 1, 2, or 3, that is constipation. All right, so should I just see to when you've raised your hand now. It doesn't show who's raising your hand. I think if you want to ask something, you can unmute yourself. Is that possible?
Yes.
We can unmute the participant. Yes, we can allow them to unmute.
Okay, so
Shanice?
there was a raised hand. You can give them a chance.
Shanice, you may unmute if that is a real hand. Otherwise, lower your hand. Okay, I think it was a mistake, that hand.
Okay.
Maybe we will
All
take
right.
the
So
hand
the
at the end. Yeah.
good. You can ask in the end as well, of course. So now we have to classify. I personally don't like classifications because I'm never sure if somebody tells me it's a 2A or a 2B or a 3C, do they really know what they're talking about? So I prefer to say, what is the etiology of constipation? And then we first have functional constipation, which is the most common one. And I'm going to spend some time on this because you will definitely often see children with functional constipation in your clinic. But then, of course, it's very important that you exclude anatomical abnormalities. And that you can only do by taking a proper history and examining the child, which includes an abdominal examination, the examination of the child's back, to see if there's maybe abnormalities there or a spina bifida or anything like that. And you have to do a rectal examination. As we've always said in surgery, if you don't put your finger in, you're going to put your foot in and you're going to miss this abnormality. Then neuromuscular ones, and we'll go into more detail about that, and some metabolic ones as well. So if we get now to functional constipation, what are the reasons for functional constipation? Now, I must tell you, I can spend an hour on every one of these points. So I'm going to make it quick and just mention all the different points. We do have milkaholics. That would be a 2-year-old child, and I currently have one 2.5 years old. Parents complain about bad appetite, asking me what can they give this child to enhance the appetite. So I ask how much milk this child is drinking. Oh, not much during the day and during the night. Oh, 3 to 4 bottles every time when she wakes up, they give her a bottle to calm her down. She's not going to be hungry and she's going to be very constipated because there's no fiber in the diet. The juice addicts is the mothers that believe that juice is healthy. And then instead of teaching their children to drink water, they teach them to drink fruit juice. And I actually, in my clinic, copied an article that was also published in a lay journal to say that fizzy drinks and juice are just the same. Both very high in sugar. The one is fruit sugar and the other one is cane sugar. So no, there's no such thing as healthy juice. And the more concentrated it is, people think if they've got 80% fruit juice, it's more healthy. Actually, it's worse, because then you just give them more sugar and without the fiber. The only fruit juice that's acceptable is orange juice that you produce yourself with a little bit of elbow grease. The tea lovers is, there was a stage in our country where babies were given rooibos tea and then didn't eat anything else, which is also really bad. Remember that toddlers don't always ask something to drink. You have to offer it to them. And the same to neurologically impaired children. They don't ask for a drink. So you have to give it to them. Otherwise, if there's not enough water in the body will take the water from the colon. And the result will be hard stools. That's very important to work on that one. Lack of colon discipline. Well, actually, I think maybe it's harsh to put it that way. What happens in our country is that most mothers are working. So now when the child is coming back from school or nursery school, and the child is not going to the toilet at home, she assumes he's doing it at school. When she inquires at school, they assume the child is doing it at home, and actually he's not passing stools at all. What I want to say with this point is, if you can teach a child to use the toilet at a specific time, and I suggest that you do it in the morning after breakfast or in the evening after supper. If they've got a routine of going to the toilet after eating, they'll have a colon discipline. They pass a stool and nobody is worrying where's this child actually passing stools, and maybe they're not at all. Lack of exercise is a problem with our children. They're not allowed to play outside at home anymore, or they're locked up in a flat. It's not safe to play in the streets. And of course, they've got all the screen time. Either they play TV games, or they watch TV, or they play on their tablets or stuff like that. And if you don't restrict the screen time, they won't do any exercise at all. And if your big muscles aren't working, your internal muscles aren't working either. Unavailability of toilets is a sad one that I learned about when I started this clinic. And it's actually the law that when toddlers are playing outside, the toilets should be closed or even locked. So this little child need to ask the teacher or the caretaker, I want to go to the toilet, and then wait for them to open it up and then go to the toilet. That's too much trouble. They'll just try and keep the stool back, pinch as hard as they can, and continue playing. Fortunately, there is a tendency to have a toilet routine in nursery schools, and they take them at specific times, which helps a lot with that. Psychological factors, people think that's very common, but actually it's not so common. Sometimes it's something that you don't think about, like parents moving to a new house. Everything is fine, but now the toilet is not in the bathroom anymore, it's separate. And when you close the door, it is dark inside. So this child can't reach the switch to put on the light, so they just won't go in there. So it doesn't have to be abuse or parents being divorced. Of course, it can be that as well, but that's not the most common thing that I see. I think in this 30 years that I've been doing the clinic with constipated children, maybe I've seen 3 children or 4 that was sexually abused. They present in other ways. They don't present primarily with constipation or with fecal soiling. And then, of course, side effects of medication. If you take a proper history, you won't miss that one. This is a nice one that was in the SAMJ in 1991, where you can see the little boy on the right-hand side is very worried to use the toilet because maybe he'll fall in, maybe his mom will flush him away, or maybe she won't hear him scream because she's busy with a new baby, and then he'll just refuse to use the toilet. Whereas the guy on the left-hand side, he's got a foot rest and doesn't need to be a proper stool like he's got. It can be an apple box or in adults. And I also recommend this for old age people who's constipated, even a sturdy shoe box, but your feet must be flat on the surface and not dangling around. And then he's got an inner ring inside his toilet and he's not worried, and he can sit there for his 10 minutes to teach the routine to go along with that. What are we talking about when we talk anatomical ones? We'll quickly go through them. As you've heard in the introduction, it's about 5% of all the constipated children that we see. But if you miss it for that child, it's actually 100%. So you should check if the anus is the right size. You should make sure that there is actually an anus and not only a fistula and any type of anorectal malformation. The one that's very commonly missed is the little girls, because they present with a rectovestibular fistula. They're passing stools even from the meconium onwards through the vagina. And then when you take off the nappy, you see stools. And if you don't examine them properly, you're going to miss the anorectal malformation. And Hirschsprung's disease, which is aganglionosis and failure of the internal sphincter to relax. Now, why do I put it very specifically like that? Hirschsprung's disease is the one that people are very much afraid of missing. And then often we will get referrals to please rule out Hirschsprung's disease. The first question that we have to ask is, when did this problem start? Hirschsprung's disease is a congenital abnormality, which means there might be delayed meconium and the child will be constipated since birth. And because they cannot relax the internal sphincter, it means that they cannot pass gas at all. And therefore, they've got a very distended abdomen filled with gas. But together with that, they cannot soil. So if you see a child with an old term encopresis, this can't be Hirschsprung's disease. They can't soil because the internal sphincter does not relax. And how did we get to that conclusion? Well, to start with a proper history. And then, of course, there are specific features on your clinical examination. If you do a rectal examination, you actually relax that internal sphincter. And then you've got an explosion of the stools together with the gas. That's why it's an explosion. And that's a typical sign of Hirschsprung's disease. So please don't refer a patient to a surgeon asking them to diagnose or rule out Hirschsprung's disease if you haven't done a rectal examination at least. If you haven't done that, it means you don't understand the disease and you are jumping to conclusions. Then there might be voluntary inhibition of defecation and painful disorders like fissures. It's extremely painful. And when I say severe dermatitis, I mean a type of dermatitis that we see after closing a colostomy, or more specifically an ileostomy. The skin around the anus is not used to stools anymore, and they can really have so bad dermatitis that when you take off the nappy, you actually see some blood there. And this child will stop passing stools. Never mind the age, he will just keep it back. And then sometimes we see an inborn megarectum, which is very rare. Neuromuscular ones, excuse me, I've already mentioned spina bifida or myelomeningocele, paraplegia, a prune belly. Children with cerebral palsy is very prone to constipation, and other children with hypertonia like Down syndrome, they can struggle with constipation as well. And if you know that, you will have a different approach to them than from a child with functional constipation. Now, what is then the etiology of fecal incontinence, which was previously called encopresis? And I think terminology is important. So let's just run through it quickly. We call it now functional incontinence. And that means there's normal anatomy. It is a normal child, and this child was never potty trained. When you expect him at the age of 4 years to be completely potty trained, it's not, then we call it functional incontinence. After the history, proper clinical examination, ruled out other anatomical abnormalities, then you can call it functional incontinence. And then it could be organic or anatomical abnormalities, and the most common one would be then the anorectal malformation or spinal surgery, or maybe something like a sacral teratoma that was operated on, and then they've got an anatomical abnormality, and that can cause fecal incontinence. But then functional incontinence are also mentioned in different ways. The one is retentive, and that's about 82% of the patients in our clinic, which means they've got fecal impaction with overflow incontinence. But then the non-retentive ones would be children with emotional problems. And that could be all kinds of things that lead to that one. If I could go back just to this impaction, the one thing that I didn't mention for constipation, and maybe I should mention it here, is, did you know that chronic tonsillitis can be a reason for constipation? Now, why is that? Because this child with an acute tonsillitis would have fever, so he actually needs some extra fluids, but he doesn't want to drink because his throat is very sore for 3 to 4 days. And if you don't make sure that he's taking in enough fluid, the body will take all the fluid from the colon. The first time when he's going to the toilet, it would be painful. Next time, he will just keep it back. Now, often we don't get to that answer when we ask them, do you think there's anything that could be the cause of this incontinence? But it's good to know when you have a patient with tonsillitis to tell the parents, please make sure that he's drinking enough water. Now, this one is one with a clear emotional problem. There's a new baby in the house. This little guy thinks he's not getting enough attention, so he's making his poo in the bottom drawer in the baby's room, so that even negative attention is better than no attention, and that you have to give more attention to the child, and then the incontinence will most probably disappear as well. So I've got some case studies here. The first one, a 7-month-old baby. It was referred to me by a GP with a history that the constipation is not responding to conservative treatment. With a request, please do a rectal biopsy to rule out Hirschsprung's disease. And how do you approach this referral? Now, I don't know if anybody wants to make a suggestion there, or should I just continue?
No, let's ask colleagues to raise their hands, and then we see if there's someone who wants to make a comment. Colleagues, make sure that your hand is up and it's a true hand. And have you saying your hand is up? Would you like to make a comment on this case? If it's not, please lower it. You may also type in the chat box if you have specific. Okay, George, let me allow you to talk. Just give me a few seconds. Yes, George, you may unmute.
Can everyone hear me?
Yes,
Yes, yes.
Thank you.
Yes, I think my approach for this case, given the age of the child, this is a child that at around 7 months, we basically introducing solids at 6 months. So I think the history about feeding or the introduction of solid would have been more important, laying it out and explaining or giving us an idea on what the child, what was introduced as a solid feed to this child. Thank you.
A very valid point that you've made. Anybody else?
Shanice, would you like to unmute? Shanice, ready? In the chat as well, before Shanice comments, there's a number of comments about taking proper history, do a rectal exam. I think we've been listening to your talk. Yeah.
Very important. What is conservative treatment? Yes. So if I don't know what you've done, then I can't do anything. I must get that first. Yes. And
Okay.
start with the history. That's very important.
Yeah, Shanice, you may comment.
Hi, sorry, that's an old hand. I'm not sure why it's still showing. It's not showing on my side. Sorry.
Okay. Yes, clearly, clearly you've listened to my talk. So let's continue with what do I want you to do. So firstly, we start with the history. That's the most important thing. And I always tell, the thing is, if you tell the parents I think maybe your child have Hirschsprung's disease because he's now not responding to whatever treatment that GP was giving. You know what that parents will do? They'll immediately go and Google Hirschsprung's disease. By the time when they arrive at my clinic, they are really terrified because Hirschsprung's is a terrible disease. It's not an easy like appendectomy. You take out the appendix and then the child's 100% fine. There's a lot of things going on there. And then, so I asked them, when did it start? And there are certain ages when constipation can easily start. One is when you introduce solids at the age of 6 months. Another one is when the mother's going back to work and to change from breastfeeding to formula feeding at the age of 3 months. Another one would be when they go from an ordinary nursery school to a preschool, or whenever they move and going to another nursery school and there's a change in the diet. So all of those are important. Now, right. So the duration of the problem is important with the story of meconium, specific events, as we've said now. Does this child sometimes pass through spontaneously or only after the family or the grandma or the auntie next door gave some medicine or an enema? Does this child have fecal soiling or incontinence? And that's what I've told you. If it's like that, then it can't do Hirschsprung's disease. If you don't have time to take a complete history, you have to refer to a dietitian. Make sure that you know the dietitian and that she doesn't tell the parents to start fruit juice because it's so healthy. And then we want to know, how did this child react on previous treatment? And I asked them very specific things. Was this child now on lactulose? Was he on liquid paraffin? Was this child on enemas? Was he on glycerine suppositories? Did you try Picolax? Did you give Petricor? Did you maybe give milk of magnesia? So I go in real detail and I ask all of those and see which one of them had a good result or not. And then I'll get back to why sometimes it is not working. We'll get there. And then, of course, ask in detail about other diseases and use of medicine. Now, I understand that when you're seeing a patient, maybe you've got 15 or 20 minutes. When I see a new patient in the clinic for constipated children, I used to spend an hour with them. As I'm getting older, maybe I talk more or I ask more or I'm just slower, I'm not so sure, but it takes up to an hour and a half to do a complete evaluation of this child. So if you're not sure, rather refer this child to the clinic where, so, you know, I get a salary. So to me, time is not equal to money. I can spend an hour with a patient without a problem. And I understand that in private practice, that's not possible at all. Make sure that you look if this child is malnourished. Does he have failure to thrive? Does he have a distended abdomen? Is the anus normal? Is it in a normal position? Make sure you do a digital rectal examination and look at the patient's back as well. Now, these slides I'm going to go through very quickly because they're quite busy. And this is from the chapter in the textbook that I wrote. So start with a history, a physical examination. If you feel you have to do a special investigation, just do an abdominal x-ray. But you need some experience also to decide if that abdominal x-ray is now fecal impaction or fecal loading or not at all. If you haven't looked at 3,000 x-rays, maybe it's not possible. So, but just keep in mind, I don't say you have to do it, but you could do that. And the red flags we'll mention again. If there's an obvious surgical problem, like no anus, anus in the wrong place, tiny anus, then you refer for surgical treatment. If there are no red flags, you think this is functional constipation, you now, number one, do disimpaction. And that you do with oral and rectal examination. I don't think I'll have time tonight to go into the detail of that. So you can separately email me afterwards, and I can discuss with you. There are also not only one single treatment, there are different ones. The important thing is you've got to get rid of all those stools. And then you need to follow them up and see if the treatment is working or not. If there are any red flags, still make sure if there's fecal impaction, then you still do a disimpaction. And now, because you are worried about this child, he's got a distended abdomen, or he's got failure to thrive, or something like that, then you continue, and then you can, and I suppose that'll be at the secondary or a tertiary hospital, or you refer for a contrast study. Nowadays, I definitely don't talk about barium anymore, rather a water-soluble contrast, a rectal biopsy. You could do an anorectal manometry. Sometimes we have to admit them in the ward and observe and see what is going on with this child. There's also a possibility to do a transit time, which is not easy and a lot of exposure to x-rays, but it can be done. If you now think this is Hirschsprung's disease, then of course it will go on to surgical treatment. If it's definitely not Hirschsprung's disease, not on the contrast study, you don't see a short, narrow segment. On the rectal biopsy, they see the ganglion cells. When you do the anorectal manometry, they can relax the internal sphincter. Then we know this is not Hirschsprung's disease. And then we have to go back and we have to make sure is this child disimpacted properly, and then we go on to follow-up treatment. If the treatment is effective, we do maintenance therapy. If it's not effective, well, then we'll have to see where do we start again. Now, this arrow just go to special investigations. Sometimes I take this arrow back and I take a new history and I examine the child again and see maybe I missed something, and that can help us to get there. Now, if we go into case studies, if we've got a 12-year-old healthy boy, he's got 5 years history of fecal soiling, fecal incontinence. He's visited more than 5 doctors, which it's not uncommon when they arrive at my clinic in the end. You ask some questions. It's a normal family. It's 3 siblings. There's not a social problem for that. Now, how would you approach this one? And I think to save some time and have questions in the end, I'll rather discuss with you what to do. Of course, you'll take that proper history, the one that I've already discussed now. Then you'll examine this child. If it's in my clinic, I'll do an abdominal x-ray. And in 82% of cases, they will have real fecal impaction. Now, I will explain the whole thing to the parents. Sometimes they don't even know that their child is constipated because he's passing small amounts of almost watery stools 10 times a day. And now I'm telling them the child is constipated. Actually, they thought that I'm going to treat him for diarrhea, which will be a really serious issue if I do that one. So what do I do? Let's say if I'm in private practice and I diagnose this child with fecal impaction, I will start by telling them all about the dietary changes that they have to do and refer them to the dietitian. And then the oral treatment that one can give is high doses of liquid paraffin. You can give them an enema to drink orally, and that one works the same as high doses of Movicol. You can do disimpaction with Movicol and Pegicol. And just note that Pegicol is half the amount of powder that's in Movicol. So you can prescribe Movicol for a child, and if you want to just give her half a sachet, you can give high dosages of that. One could give something like Picolax, which works very well, but then you need to make sure that there are not any other problems going on there. So I said again, the history, and this is what I spend really long with the parents to ask in absolute detail what is going on, even who's staying with you in the same house, the medical history, how's it going at school. And these children with fecal incontinence will come and tell us it's going terrible at school because he can't sit still because he's smelling all the time, and other children is making fun of him. Ask how did the bowel habits develop? Are there any emotional problems? How is he sleeping? Does he have urine incontinence as well? And then the history of the incontinence. How did the family react to this? Is most children are not concerned. They couldn't care less. They just want to go and play. And that makes the parents very angry. How can you be 8 years old and you don't mind if you're smelling like stools? And the children say, I don't know, whatever. And then important to know if it's a difficult or an easy child. And then you see this one. He's playing, he's got poo in his pants. It's like a bomb there. It's smelling. Everybody coming into the room can say, hey, you did it again. He said, no, I did not. Come here, let me see. And now you're lying as well. You are really a naughty boy. And this you have to explain to the parents. They're not naughty. They really lose the sensation of their rectum when they have this serious fecal impaction. They just don't feel the stools. They don't get the urge to go to the toilet. Right, clinical examination, general, abdominal, PR again. Special investigations, I will start with an abdominal x-ray. You could do a defecogram. I'll show you an example just now, which is give you an idea of what is going on. Anorectal manometry will also help you if it's a bigger child specifically to make sure there's not something else going on. This is an x-ray of a child with fecal impaction, and right from the right-hand side of the colon, you can see stool sitting there. Over here, you can see some balls that you can visualize there coming down here, and you see the rectum, size of the rectum. It fills up the pelvis completely, which means when this child has to pass that stool, it's like giving birth. It's really painful. It's a massive stool that needs to come out. Sometimes we have to admit them, give them sedation, even take them to theater and do a manual disinfection there. This is an example of a defecogram. So it just shows you that there's a massive dilatation of the rectum and the rest of the bowel is normal, which tells you this is fecal impaction. This is in Hirschsprung. In Hirschsprung, you've got a narrow segment. Here you've got a dilated rectum. And then very important, if you ask for a contrast study to rule out Hirschsprung's disease, make sure that they don't blow up that balloon, because the balloon can obscure the narrow segment of Hirschsprung's disease. There should not be an inflated balloon when you do that contrast study. So disimpaction, most important, dietary changes, teach them a toilet routine. They can even keep a calendar. We've got a physio that can teach them how to properly sit on the toilet, and I've got nice pictures to teach them that as well. And then I follow them up very often, initially weekly, and then 2 weekly, because you've got to do quite serious treatment for this child. And if you fail because you followed up in a month or in 3 months' time, this child is not going to believe you anymore. So you've got to do it on a weekly basis and make sure that you get him there. And if there's no improvement, well, make sure that maybe you didn't do a proper disimpaction or impaction happened again. And then that I would personally do an abdominal x-ray to show that again. Now we get one that I would like you to give me an answer. A 10-year-old boy that presents to casualties with recurrent episodes of fecal impaction. He did have a contrast study for chronic constipation. And now, what do you think is the most appropriate investigation that you should do? There you have. Do you think we should ask for a rectal manometry? Should you refer the child for a full thickness rectal biopsy? Maybe you can ask just for a suction biopsy or another water-soluble contrast study, just a plain abdominal x-ray. Maybe you should do a CT scan. That might help you to rule out other stuff. Maybe ultrasound or maybe nothing. You can now answer the poll if it's possible. I don't see any answers yet. Are you still thinking?
Colleagues, are you, oh, the question was too quick. Are you able to see it? I'm not sure if there's a challenge.
We can see the poll. I think you just can't select an answer. I don't know why.
Let me share again. Let me try again. A few seconds. There we go. We can see it, but can't answer. Oh, I'm not sure why. Oh, okay.
Yeah, it's not allowing for one to pick an answer, but it's there.
It might be.
It's fine. Maybe we should continue. We don't have
yeah,
a lot
okay,
of
it's
time.
okay.
Okay, you can close that one. And that's quite a mouthful and a lot of things that you feel you should do. What did this doctor do before he referred the patient to us? He actually, oh my goodness, what's going on? He did a CT scan. So I'm not sure if I should say this, but sometimes I tell the student, I haven't seen a more shitty reason to do a CT scan than this one. So what should you do? You should actually just check the abdominal x-ray and see if this child still has fecal impaction or not. And then if you're not sure what to do, rather refer this child before you ask a lot of special investigations. Recently, I had a patient that the parents didn't have money. So the family paid for the CT scan just to show us that there's fecal impaction again. It doesn't help us to rule out Hirschsprung or any of the others. So you still need to go back to basics. Take a history, examine this child properly, treat the fecal impaction, and then only do you go on to other special investigations. Now, I've just wanted to mention some children with anatomical reasons for constipation, a child with an anorectal malformation, fecal stoiling still by the age of 5 years. Should you do some special investigation? Should you do colonic transit time? See where the problem is? Maybe you should do a sacral x-ray, maybe an MRI. You can pick up some serious problem there, or a contrast study, or a colonic manometry, or maybe you should consult a specialist. All right, there you can answer now. I see that. I'm not sure if you can see the results as well. Majority says consult a specialist. Some want to do a colonic manometry. Some 20% says a contrast study. A few really wants an MRI. All right. So what should one actually do? One should do a sacral x-ray. And the reason for that is you're looking for abnormalities of the spinal column and see what is going on. And if it wasn't done before, if you have some other red flags, then you can go on and do an MRI. In the majority of cases at the specialist clinic, and I would not complain if you send it to the specialist clinic at all, because I think this child actually with an anorectal malformation should be followed up at the tertiary hospital until school going age. And when you do the sacral x-ray, you can also evaluate if this child has fecal impaction or not. And then you can first treat the impaction. Sometimes they have diarrhea, and then you've got to address that. It depends on what was the result of the anal surgery. Does this child have some sphincter control? Does he have an open anus? Is the anus now in the correct position in the center of the sphincter complex? And then if all of that was done and the child just doesn't have proper sphincters, what can you do? Then definitely in a specialist clinic, we can help them with a special bowel management program where we do regular bowel washouts. We teach the parents to do that, and they can at least be socially acceptable. And then I think this is almost the last one. We're now at a 7-year-old, and she has a normal sacrum. She has a dilated rectosigmoid with significant stool load on the contrast enema that was done. And what should you do now? And I think you should evaluate all of that. Most probably, oh, you want to poll again? Yes, let's quickly see. Do you want to give stool softeners, or do you want to combine it and just call it disimpaction? Most probably that 70% of people are saying that is correct. And every child is different. There's not a single recipe that I can tell you what is going on. If they're constipated, you need to give stool softeners. The laxatives, I would give like a Senna product once a week for 6 weeks to make sure that that one is coming out. I'll teach them to do a proper routine, and definitely not a sigmoid resection. I might add some enemas if it's working, if they do have control. If they don't have control, it doesn't help to give an enema. As you put it in, it will pour out, and it would not empty the rectum. I don't think we've ever done a permanent colostomy. Sometimes I felt like it is necessary. The thing is with the anorectal malformations, especially in the boys, which is more common, and they have poor sphincters, nothing that you can do. It's a high malformation about that one. And then I personally think a permanent colostomy is the best solution, but it's not acceptable socially. They're not allowed in normal schools. They're not allowed in nursery schools. Sometimes the mother has to give up her job to look after the child because even the granny don't want to look at the child where a piece of his bowel is outside his body. And so that is not a practical option. The Malone appendicostomy is one in older children, and that would be an antegrade enema, which means you make an opening in the cecum, and then you do a washout from there while the child is sitting on the toilet. But this is a highly specialized thing, and that is an option that can actually work. All right. So this impaction is correct. This is just to show you Prof. Albert Pena from Mexico, and he visited us twice here in South Africa that I know of. And he's got this textbook about surgical treatment of colorectal problems in children, but it all goes about anorectal malformation or Hirschsprung. And this one I'm not going to talk about. It's just to say that sometimes fecal incontinence go together with urine incontinence, and this is just terminology for that one. My take-home message is you're going to see many patients with constipation. Not all of them need special investigations. Make sure that you take a history and red flags to look out for red flags and clinical examination. And then to prevent a delayed diagnosis, just be a good doctor. Evaluate your patients properly, keep the family informed, and follow them up. And if you see what you've tried, your conservative treatment is not working, then please refer. Always start with the basics And don't assume that a common complaint is not serious. I presented in 2018 at our Pediatric Surgery National Conference 4 patients. 2 of them had lymphomas, and the one even a rhabdomyosarcoma presented with constipation. It was missed because somebody just treated the constipation. On the other hand, there were 2 patients with serious constipation, one like that CT scan I showed you, a lot of special investigations done just to find that this child has got fecal impaction. So where do I get my information from? I attended some of the International Children's Continence Society's meetings, and I read their documents. I'm subscribed to receive any new articles about constipation from our library, and then I just have experience in the clinic. All right, I'm sorry that it looks like we've got 2 minutes to go. If there are any questions, I'm going to take them now.
Okay. Thank you very much, Dr. Kirsten. Your talk was very eye-opening. I had some questions before you started talking, and I think you've sort of answered some of the things that I was thinking about when I was thinking about your talk tonight. I thought about the challenges that our current lifestyle poses to our children, the busy lifestyles that we're having, where the child is having multiple caregivers. There's the parents, there's the daycare, there's the nanny at home. And yeah, you've touched on that as well, where we would all assume that somebody saw the child pass stool, whereas the child didn't pass stool at all. Because the child is being cared for by multiple people. So you touched on that. It's something I was thinking about. You've also, when you talked about functional incontinence, retentive and non-retentive, before you spoke, I had a little bit of confusion about that. I had some questions to say that clinically, how would you differentiate overflow incontinence from just fecal incontinence, maybe from either a sphincter problem or a child who's having malformation or something? So
can I answer that one now?
Yes, you may.
Okay, you'll find that with the history and the clinical examination. You'll find the fecal impaction on abdominal examination, or definitely with rectal examination. You can't have an empty rectum and have fecal impaction. So if you do a PR, you'll feel the rocks there, and then you know this is impaction. Yes.
Okay, and then you'd know this is overflow then. Okay, yeah, because the other thing I thought about was fecal soiling and diarrhea. But when you were speaking, I listened carefully and I actually found the answer to that. I think from what I got from when you were speaking is that both of them is that the patient might be leaking with fecal soiling. I think the difference would be volume, because both stools will be watery, but with fecal soiling, it may be watery, but little frequent stools, whereas diarrhea involves frequency as well as volume. So that's what I got. I don't know if I understood that right, if I were to differentiate fecal soiling from diarrhea.
So, but still, people sometimes think, really, if a child has got gastro, should I do a PR? Well, if it's a chronic thing, you definitely should do a PR. And sometimes even an acute case, a child can have diarrhea, and that could be the cause of intussusception, and then have an acute abdomen, and you won't find that if you don't do a PR. So the answer lies in the clinical examination of the child.
Okay, yes, and then my last question is similar to what somebody else asked on the Q&A. Carl Richards asked about the role of probiotics in the management of children with constipation. I also had that question as well.
Yeah, I've never prescribed it myself, but in our hospital, the dietitians actually believe in it. If it works or not was reported just in the past month in a proper trial that was done, and they didn't show any difference whatsoever. But sometimes if you give the mother something and you're very positive about it, it might work, or she might just do all the other stuff as well because she's now giving the probiotics. So I don't think it can harm the child, but it was actually didn't show in a double controlled trial, didn't show any useful there. So why is it normal for a neonate to pass stools once a week? It's not normal for all neonates. It is a neonate that the mother's got just enough milk, and maybe she's feeding strictly 3 or 4 hourly. The child absorbs all the milk because breast milk was designed for babies and cow's milk for cows. So the baby is absorbing everything, and there's not a lot of residue, and that's why it's possible that they can pass stools very irregular. So it depends on how much milk the mother has. Then ADHD children, well, it depends on the reason for the ADHD. One of the reasons for ADHD that's sometimes missed lies in the diet. If they're taking in too much sugar, they're hyperactive because of that. And then they don't eat high fiber food. And that's possible that they can develop constipation from that. But it's not specific. We do see ADHD children with constipation and even overflow incontinence, but I think there's not a direct reason. Mostly it's a lifestyle reason. I would prefer not to answer the question about the pregnant woman because that's completely outside my field. So I might say what I think, but that might not be the right thing to say. And then is barium studies relevant in children with constipation? Well, actually, I would not use barium at all, because if there's a problem like Hirschsprung's and you put in barium, he's not going to pass that. And barium can become a rock hard in the bowel, which can cause later on a serious problem. So a water-soluble contrast, if from your history and your clinical examination, you think this might be Hirschsprung's disease, then we do a contrast study. And then with that contrast study, we look for the narrow segment that can be an indication of Hirschsprung's disease. And then, of course, we'll continue and do a rectal biopsy on what to do if a child is affected by formula feeding. Well, I would firstly say give this child some water in between. That's the best treatment for constipation is actually water. And then from what age, or the other thing is if the stools are really hard, especially initially, from newborn age onwards, you can give them glycerin suppositories. It doesn't have an active substance. It stimulates the rectum to pass stools, and or if the stools are very hard, it will dissolve and lubricate the stools, and then it will just come out more easily. From what age can we do a PRR examination? From birth. And if you think your pinky is too big, then in the tertiary hospital, we'll use a tiny dilator to see if it's a fistula or is it anus or does it contract properly. Or a tube that actually works quite well to use in a small baby is an ESR tube, the tube that you use for taking blood. The ESR tube has got a very nice rounding, and it's about the size of a 9 yegar, and that can work quite well. Constipation that may be caused by trauma from child abuse, which is more relevant nowadays, emotional trauma to the parents, physiological. Yes, I think in these cases where they are trauma, we won't ever use any rectal treatment. So we won't use enema, so we won't use suppositories, especially not initially. We'll make sure if this child now have a build-up because they don't want to go to the toilet or they're afraid or it's painful. And then we'll get a psychologist and even a psychiatrist involved or a social worker, and we take it from there. So it's a multidisciplinary approach then. You can't just treat the constipation. You've got to treat the underlying problems. Does glucose to go or is diet or formula? No, I think most probably it's just diet or formula. What are the oral medications for disimpaction and daily enemas? Perhaps laxatives. Because that's what's available in our state hospital, I use a lot of liquid paraffin, and there's 2 different formulations for the dosage. The one is for disimpaction, which is massive dosages, and the other one is for just to keep maintenance treatment. So there's 2 different dosages there. I give the liquid paraffin to help them to make the stool soft. And then if the child allows me to do a PR without screaming and fighting all over, then I'll consider daily enemas. And I never use a pediatric enema because that bottle is very difficult to press and get everything out. I use the adult one and then only use half of it, put the air back in, and the next day use the other half. The reason for the enemas is 1, to make sure that the child is passing proper stools. 2, it's almost like a biofeedback, so that when you give the enema, they know they have to go to the toilet. So if you keep on doing that at the same time, later on you can take away the enema, and after breakfast just put them on the toilet and they will pass stools without the enema. So that's just not a permanent treatment, but you can continue for several months if it's necessary. I say you, but I mean a specialist clinic. How does the spine have an impact on the bowel? If you've got a tethered cord, or if you've got a spina bifida or myelomeningocele, you don't have proper innervation to the perineum, and that's how that one causes it. Then there was a question about prune juice. I think if the child if you want to give the prune juice instead of some fruit or as an additive to the rest of the diet, yes, then I would agree to that. But prune juice wouldn't work for impaction. For impaction, you have to do something else. Yes, asking about the enema, I definitely think so. The people in the UK and Australia, they don't like enemas, but US people use enema. So you never, ever force that on a child. If he wouldn't allow you, you can't use it. The child has to give consent to use an enema. And then in today's era, you can definitely do that. And
there was a question about the absolute indications for biopsy apart from H. springs. I don't know if there's any other indications.
No, well, I wouldn't say absolute indication, but there is one condition that I didn't even mention here today because it's quite rare, and that's a leiomyopathy. To start with, in the history, these children are normal, passing normal meconium, normal stools, and then around about 3 or 4 years, they start becoming constipated, and then it gets worse and worse. And when you see the child, he's got this terrible distended abdomen, just like Hirschsprung's disease. When you do a PR, it doesn't have an explosion. When you do a contrast study, it doesn't show you much. And then you decide, well, this abdomen is so descended, I would feel better if I can just rule out Hirschsprung's disease. But in that case, you have to do a full thickness rectal biopsy, not only ask for ganglion cells, but also for the examination of the muscle. because this is a degenerative leiomyopathy, which means that it's a progressive disease, and it also affects the urinary tract, and in the end, they die as teenagers of kidney failure. But around about the age of 6, 7, they look like a missed Hirschsprung. And with that biopsy, you will rule it out then. But there's not another indication for a rectal biopsy except for those two.
What a powerful,
Okay, no.
complex, simple thing. Yeah, okay, continue, Doc.
No, I just wanted to comment on what Dr. Kirsten was talking about now, because we currently have that kind of patient. We have a 13-year-old who also just presented with progressive abdominal distension. And when we do X-ray, it just looked like the patient has massively distended colon throughout, from the ascending colon, transverse, sigmoid, everything massively distended. However, he has no pain. It's
no, they don't have pain.
They don't have pain at all. And when you're looking at him, it looks like it's gonna burst.
Sometimes they look like they're expecting triplets. That big as their tummies. And that could be a degenerative leiomyopathy. And in that case, you have to do a biopsy to make sure what is going on. The oldest child that I've seen with Hirschsprung's disease, a missed Hirschsprung's disease, was 10 years old. So that is possible, but I think that was about 20 years ago. So hopefully nobody's making that mistake anymore. But this one sounds like a leiomyopathy. And the interesting thing is it's a disease of Africa. It wasn't described anywhere else in the world, not in Australia, not in America, only in Africa.
So we're still waiting for the biopsies to be reviewed, because he had the full thickness biopsies of rectum, ascending colon,
then
as well as
when you
right
read
colon.
the report, sometimes they don't comment on the muscle. They have to say if there's degeneration of the muscle as well.
Exactly. So what you're saying is what happened. The report came back and they said no abnormalities noted, but we had to phone back to ask them to review it. So we're waiting again for them to review it.
Absolutely.
Empowering. There was just another small comment about over-the-counter magnesium salts. I think that might be.
I saw that and I missed it. Yes, I think it's not a serious problem, and it will not cause constipation in the end. But in a neonate, I'm always a little bit concerned about electrolyte imbalances. So I personally give this baby rather some water and glycerin suppositories. That's safer. And then if they really now struggle a lot to pass stools, if the mother gives the milk of magnesia once a week or once every second week, until often that resolves when they start with their solids and they're eating fiber, having fiber in their food and so on. So I've never prescribed it, but, and I also didn't have a lot of mothers saying it worked well. So I think the ones that it worked well, they don't end up in my clinic. But if they've got serious constipation anyway, it's not working. But it won't cause constipation.
Yes, what a great session. Dr. Bachet.
There's a lot of positive comments from the audience. So this was very informative. Many of the comments, they enjoyed the presentation, and so did I. And I think we've answered most of the questions. And we are unfortunately 16 minutes after 7, so we have run out of time. And I think I should say thank you very much, Dr. Kirsten, for your time and for your talk. I think we've all learned a lot from this. And I think if others still have more questions, we can still forward them to you, and I'm sure you'll be able to answer when you have time.
Yes, they can email me, and then I can answer when I have time. And it's, I think, I didn't spend a lot of time in the detail of the treatment because it's so diverse. I can talk an hour about that.
Yes, yes. All right. No, thank you very much, Dr.
Oh, there was one thing, this soapy water. No, I don't like that at all.
the homemade
Yeah.
enema.
No, the soapy water, I know they also make sunlight and sugar
the green bar.
suppositories. I don't like that at all because it's very irritating and it can cause some inflammation of the rectum. So no, I don't like that. Rather use then a plain water enema or a glycerine suppository. That's much safer.
Yeah, for me, Dr. Kirsten, I would say the parents shouldn't give the children enema unless it's prescribed by the doctor, because
I agree.
they might cause trauma if you don't know how to insert it into the rectum.
Yes,
and then it
absolutely.
also causes trauma. So I think they should not use it unless they have been shown how to give the enema
Absolutely.
in a safe
And then,
way.
you know, the goggles, I had one, they showed me the other day how they let the children kneel when they put in the enema. You know, the children feel so exposed and they're
Yes.
so frightened. And if it's a goggle that's very strict, then you just have to stay still and get it done. And I don't agree with that at all. A child's got to consent. And when I give them an enema or prescribe it, I let them lie on their left-hand side with their knees bent, and then you put it in from the back. Yeah.
No, I agree with you in that. Dr. Mawela, I don't know if you have any closing remarks.
No, just to thank you, Dr. Machete, and importantly, Dr. Kirsten, for your time, for this opportunity. You know, when you say constipation, it sounds very simple, but from your presentation, I see that it has its own science. It can be a bit complex. And hence, I think most people enjoyed your talk as well because they could relate. And you seem to be a very great teacher. I think you need to come back so that we can discuss some of the conditions and especially around the treatment approaches. We have laid the foundation. There's also a comment, I think at the 19 hours from Renee, where she says, hey, thank you, Dr. Kirsten. I still remember your talks back from Steve Biko. So it seems like there's a lot of your mentees in the group.
Thank you very much.
And they really, you know, appreciate it. And what I've also learned today is that experience is the best teacher. Yes, we do read books and articles, but you have shared a whole lot of background information, which is going to be very helpful for the kids we are going to see tomorrow. So we really appreciate you for